Let's do this. So, Melissa, first of all, thank you so much for making this Unconverence come to fruition. I think it has been your brainchild, your idea that you pulled together. So I would like to use the next, how much of our time we have, probing into the mind of Dr. Cole, Melissa Cole, and figuring out innovation does not have to be the widget that we all think it is. And from my vantage point, looking in, you have had a very unconventional path to where you are sitting right here. My simple brain sees you, or has seen you as an inpatient or a acute care executive. You've been on the bedside before that. You've been on the post-acute strategy. You have now evolved into academia. Tell me, how was that journey happen?
Well, I never thought I'd be sitting here in academia until I was retired. So, and I don't think I'm old enough to retire yet, Balaji. So I think I got some time. But I'm really glad I made the change. But yeah, as you said, I actually graduated from Ursuline, started my career at Cleveland Clinic in the neuro ICU, and was a neuro ICU nurse for several years. And my husband and I, funny story, were married, divorced, and remarried. So I've married the same man twice. I guess I believe in second chances. But we decided to move down to Tampa, and down there, that's where I met you. I was the emergency services director, so worked for a for-profit for a little bit, worked my way up from critical care nurse manager to neuroscience director, and then decided I could run trauma programs. If I could do stroke programs, I could probably do trauma programs. So I would say as a leader, I have not always led units of which I had competency clinically. And so I had to learn how to be adaptable, flexible, understand leadership principles. And man, my first 360 evaluation was a bomb. It was a wake-up call for me to understand that the things that made me a really strong nurse, a patient advocate, I could speak up, I was a problem solver, did not make me a good leader. And so I went to boot camp at Tampa General. I did the Great Leaders Franklin Covey course, and had a great mentor in Dina Nelson, who was our CNO, then COO there, and she took me under her wing and she said, let me help you. And I was the director of emergency services. We had an abysmal of an emergency department at Tampa General. So I had no idea how to lead emergency departments. I was the trauma program manager. I just knew that I liked that environment. And thankfully I had Dr. Ween, who was my first time working in such a strong dyad relationship. So that's where I think I began learning that I didn't have the clinical competency, but I was partnered with somebody who did. He was an emergency medicine physician. And also the important perspectives, I think, that my training as a nurse, his training as a physician, and then Dina's training as a leader, right? And you add you to the team as the CIO, and then you begin to gain these perspectives that sort of make this work. And so we had a 20% walkout rate. So that means 20% of our patients that came into the ED did not get seen and left because the wait times were too long. And so that's where I learned about operational effectiveness, design, and really how to innovate, but also how to change culture. And that became really appealing to me because I think as you want to change culture, right? I mean, this staff was so demoralized. The patients weren't getting seen. They left with a full waiting room. They came back to a full waiting room. There was like you talk about burnout and moral distress. Talk to a nurse who just can't feel like they can get their job done at all in an emergency department where we count seconds and minutes because lives matter. And, and this team too, we had WellSoft, we went live with Epic, and they cut all the scanners for medication barcode scanning with the trauma shears. So this was the type of team I was leading. So anyways, it was a really humbling experience. And so I think, Balaji, even though I never have thought I would be in the academic environment, I feel like this is mission-centric, and I'm getting back to my purpose, because I had gone through executive roles. I had moved back from Tampa about 7 years ago. I started working at UH. I got to work with UH Ventures and learn like the formalities of how you innovate and how to work with companies, et cetera. And I think what I realized during COVID, and you heard a lot of it today, the health systems are handicapped by the fee-for-service model to a degree and are unable to innovate, I think, as much as they would like to, because we're stuck in a fee-for-service model. So our ability to take risk, our ability to truly move to value is stifled. And so I thought, here we are, we've got nurses burning out, we're in moral distress, our teams are kind of breaking down. What legacy do I want, or what is my purpose? And this opportunity at John Carroll came to start a brand new nursing program in a college of health to design the healthcare team of the future. I don't necessarily have competency in academia, right? I've done teaching on the side, but I have competency in building relationships. I've got competency in building teams, transforming culture, and thought, wow, what a way to kind of go out, have in my career to be able to inspire and influence what the care teams look like and act like in the future. And imagine 200 John Carroll nurses coming out and feeling empowered and knowing how to innovate and being able to transform healthcare. And so I said, well, I'll give it a whirl. So it'll be a year next month. And I think I'm a little crazy to try and throw a healthcare conference within the first year, but why not?
Why not? Here we are.
Yeah.
We're almost done. But I think you're talking about one of the core competencies of innovator, right? Innovators, we kind of have this very fancy view. I think that was Lisa's question to the team. We have this clouded image of Elon Musk or Bezos or unfortunately other models. But innovation for me, I want to ask you a question, the audience a question. Name a female business leader that is their biggest business leader in the country right now.
Taylor Swift, Beyonce.
Taylor Swift. Taylor Swift is it. And I think that is not because it's like, we all think about this as in one different way, but for me, the competency you bring in is you're comfortable being uncomfortable. And that is a very unique trait of an innovator, right? So now I'm going to take that and derive what you did at Tampa General in the inpatient setting or in the ED. You were able to innovate. You were able to ask unconventional questions that changed how Tampa General functioned. And then I translate that to University Hospital. You're unconventional, or maybe you're being humble about this, saying, I don't know, I don't have the competency, but there came the hospital at home model, one of the first in the countries. So I'm going to now extrapolate and give you the opportunity. What unconventional thing are you going to do as the interim dean?
Oh, I've got a list right now.
I'll take it.
No, I think when we think about the healthcare team of the future, and you heard a lot about it, I think from the last business panel, who talked about some of the things that are non-negotiable for our consumers anymore, our patients, what they need, what they want, right? They want digital, they want access, they want to be fully cared for, they want to be fully seen. We can't separate their behavioral health from their physical health, and how do we do that? And so when you think about this integrated delivery model, I think what we want to create here is an integrated delivery model of how we begin to deliver education and training for physicians, pre-med, right, students. How do we begin to train nurses with those students, dentists, right, DOs, MDs, right, pre. How do we begin to integrate counseling, BCBA, exercise science? How do we begin to maybe start a public health program in the fall, or a bachelor's in healthcare administration with the Buller College of Business? And how do we begin to influence each other, start to train each other under one common language? I mean, part of the issue is, as a nurse, I speak Mandarin, and the physician sometimes speaks Japanese. It sounds similar, but they're not the same language. And so how we begin to train that interdisciplinary team for the future and create that under the College of Health, I think is pretty innovative. Most of the time you see schools of nursing sitting outside of different disciplines within academic settings. Some of that's pride, some of that's ego. Same with medical schools, sitting outside of all the other things. I don't think one is better than the other, and I think that silo has been detrimental to how we function when we get out and being able to tackle these healthcare issues we talked today. Additionally, we talked about nurses, and we talked about them inventing tube feedings and colostomy bags, and nurses have been told they do workarounds for decades, right? We're just going to do one more workaround. And these are actually problem solving. These are innovations happening. So one of the things we talked about here was that for our nursing students, they're going to graduate with 4 certificate programs so that they can help be better prepared, not for today, but for 4 and 10 years from now, because that healthcare system, like you glimpsed today, is going to be very, very different. So we partnered with Buller College of Business, and a lot was being modest. Doan Winkle, that leads the Masters in Science and Innovation and Entrepreneurship, is delivering 15 hours of innovation and entrepreneurship to our undergraduate nursing students before they graduate. So they know creative problem solving. They start thinking about how you innovate. You know, Balaji, you and I have talked about how can we get every nursing student in LLC to learn how to manage. The other thing we've done is we've partnered with our counseling center. So Catherine and her team are here, and we are delivering 15 hours of self-care and resiliency training. As you heard before, self-care and resiliency isn't going to save the healthcare provider tomorrow, but that toolbox is going to be helpful as long as our healthcare partners continue to also want to address some of the workplace issues that we're tackling, and that's why Meredith and Michelle were here. The other thing we are looking at is, and offering a certificate, is in leadership development. Many times nurses in particular are orchestrating the care of all the other disciplines, the dietitians, the pharmacists, the physicians, coordinating care, and so making sure they have the skill set to communicate and know how to do that. Like I said, my leadership journey was a surprise to me. We should not have surprises. Yeah, so that's 3 I mentioned. I'm missing one, hold on. And DEIB, how could I forget this? So Michelle mentioned, you know, right now nursing has become a white middle-class profession. It's where we've been, but that's not the communities we serve. And so we have to do a much better job of making sure we're attracting and supporting, but also providing equitable situations so that we can increase diversity in our profession and also train under diversity, equity, inclusion. So they'll get 15 hours of DEIB training. All of our faculty and students have to take the Harvard Implicit Bias Test, not just on race, social class, obesity, you name it, we have biases, and it's just bringing that to light. So those are a couple of the innovations, and I think those certificate programs that we started in nursing aren't unique to nursing, and I think other professions can use that, and hopefully that culture will continue to spread.
Oh, wow. You have a full docket.
I do. I mean, I got at least 5 years here.
So, when you think about your journey, or anybody's journey, I want to get to the most vulnerable spot, because that's what declares to the world who we are and who you are. And I'm going to kind of put you on the spot and ask you, life is never like a cozy fireside chat, right? We are talking about all the good things that we have seen, that you have done or we have done. Talk to me about a spot where it has not been easy. We know it did not come natural, but I can only imagine there are spots of profound confusion or unsettled nature. And I feel like that's inherent to innovation, right? So, clue us in.
I talked about my 360 eval, which that was a real bummer. That took a whole bottle of wine to get through that night. But I don't have a problem, like Meredith said. I would say this transition to academia, I mean, there are gaps I have. So I went from an expert from how to deliver healthcare in emergency departments, trauma units, I was looked at, sought after as the expert in healthcare systems for the last, 15 years. And coming to academia, understanding just the tenure system, how that works, what that means. And so this has been and I think that's where we grow. I'm really uncomfortable today. I've made some mistakes. I'm probably going to make more. I know I'm learning. I know I'm growing. But those moments of the shame, the guilt, like, how could I not know that? What am I doing here? Oh my God, I should go back and do what I know I should be doing. But those are moments like innovation, right? I think that you have doubts or insecurities as you're doing things you're not always comfortable with. And I would say, this first year, I'm doing a lot of things I'm not always comfortable with and have made mistakes along the way. And I don't know, for all the nurses in the room, I'm a recovering perfectionist. And so when you make a mistake, it feels like the end of the world. And so, learning to work through that, never make the same mistake twice. But those are moments where I've relied on my friends, my family, my colleagues here for support and help guide me. And they're sort of necessary, but it's an exercise in humility, starting a new career.
And that's where innovation begins. That's where new things happen when you're uncomfortable. So I'm glad you're uncomfortable and stay out of that wine bottle. So, one of the biggest theme of today, I don't think we planned it this way, but it happened this way, rightfully so, has been nursing shortage. So, kind of rapid fire at us. What are you going to do to help that? How is John Carroll, how is this program going to fill in? I think the 200 nurses graduating would certainly change the map in the local region, right?
Yeah. Well, I think, one of the reasons, and Michelle talked about how we got here, it's been an evolution, and nursing shortages are cyclic. They've existed for decades and decades upon decades. This one is unique. I think we want to believe that, but probably isn't as unique as we anticipate. And one of the things we've always struggled with is nursing programs are stunted in their growth because of clinical faculty, not being able to find enough clinical faculty that's at the bedside that meets the state regulatory requirements or the accreditation standards. And it limits you, and there's caps on how many clinical faculty to X students that you can take. Additionally, you've got only a limited number of sites, right, sometimes. So one of the things we're doing to try to combat that will keep us growing is many times the schools will hire the clinical faculty. But instead what we're doing joint appointments. So our anchoring institutions, Cleveland Clinic, Metro Health, and UH, are open to saying, yeah, we'll continue to employ the clinical faculty because I only need 126 hours in a 16-week semester, or really 8 weeks of that. And they can keep their full-time status, and you can lease them from us for that amount of time. And they can perform the education that they need to on the unit that they're familiar with. They can train, and then, we can continue to grow our program. And this model is innovative in nursing, but this model is just adapted from my physician colleagues my physician colleagues are expected to do research and to teach as part of their appointment in an academic medical setting. And so why don't we expect in nursing that our nurses are expected to teach, do research, right, as part of what they do each and every day? And so that's something we have to collaborate on, though. I can't do that all by myself here in academia. Academia kind of needs to get together, as well as our health system partners. And then when you think about the retention later, right, that nurse has been on that unit, has worked with that nurse side by side, has grown mentorship and support. That helps longevity and success. We believe it will decrease turnover in the long run, as well as support the need for nurses in all three of these institutions. So Balaji, do I get to ask you any questions?
Do you want to?
Yes.
Have to?
Yeah. Yeah, so I think tell the audience a little bit about you and how you ended up here at Agility. And then I'd love to open it up to the audience. I've got some questions for the audience, but tell the audience about you. I mean, we're like the odd couple.
Yeah.
I mean, and we've been friends for a decade now.
Yeah, there's a lot of ways to get it out, so yes. So like everybody else that was here today, the story for us is, you find a problem and you find it in a spot where you are not expected to find it. I had the privilege of working with her at Tampa General, got recruited to go to Stanford in Palo Alto. That's where I met Lisa, who held a panel with the nursing team today. And the question there, we forced the question and say, if money and technology and smartness were not all the limitation, what problem would you solve?
I would say human rights problem.
Oh,
Social
well, that's,
innovation, because we'll be talking about innovation, and these are basic human rights.
yeah.
And also transparency. I think there was another example. where-
Bias?
Biases.
Absolutely.
Yeah.
But that's, I think, you see, now, there are flavors of this question. Now imagine asking this question at Stanford. Because everybody at Stanford is smart, right? They are the best person. I mean, how do you tell them what innovation is, Because the minute you open your mouth, they're going to tell you why there's a better one. So the best way to handle it is ask them, if money was not a problem, what problem would you solve for? The beauty is, Stanford did not have a cohesive answer. And it's not a function of Stanford, it's a function of health systems. There are so many nuances, there are so many different flavors, there are human rights issues, there are bias issues, there are basic staffing issues, basic scheduling issues. So the gap is so wide. So our journey began at Stanford to say, wait a minute, you can have fancy robots deliver food, you can have amazing automation, you can have web portals, you can have apps. If you can't discharge a patient, it doesn't matter. We kind of made fun of it, right, Lisa? We were like, you can have fancy marble flown in from Italy to make your atrium. It's still the same bleaky care. And that's our journey. So our journey is we need to fix the grunt work. There's so much basics, blocking and tackling that needs to happen. That's not innovative. I love what Julie said before. It's not, oh, you asked the question. It's not innovation to us. You don't have to call me. I won't be insulted. Don't call me innovative. Just call me, I'll take your laundry out. I feel like sometimes we are the ditch kickers. But we have a very important role in society, and that's okay. So that's our journey. Thanks for the opportunity. So we help hospitals manage throughput and get just day-to-day stuff that trips them up every single time. We try to help them with that. But,
Your waste management.
that's it. Pretty sophisticated one.
Yeah.
But isn't that the goal?
We're moving
Here we are.
waste out of the system.
You cannot load the nurse one more thing. So we align with the mission that you are on, is we have to train nurses differently. We have to train physicians differently. We have to give them context. We have never given them context. We have treated physicians, even physicians and nurses, as, oh, you are pretty good at this, you keep doing this, and you keep doing this, and then there's layers of middle management that get stacked up to run the hospital. And that very uncomfortable question to ask is, healthcare has a middleman problem. So, yeah, so we can go at this fireside for a long time.
I want to hear from them.
Yeah.
What questions do you have for us?
Special.
I mean, that's a very good question. I don't know that I have the answer. I mean, we're still working on, just even in the healthcare space, having a common language, right, among healthcare providers. I think it's a great goal. It's a great thing to ideate over, and that's the idea of today, is to think deeply about these things, right, to ideate on them and then begin to truly understand what the problem is so that we can then find a solution. Do you have a comment on it?
So these are big problems.
Yeah.
I mean, I think all you're going to get is, see, this is how the language problem is, right? I don't even think I understood exactly the scope of what you're saying, right? And it's okay to say out loud, I just not. And it's because I'm not a philosopher. And for us, we're all stuck in, we're all in our spots, but it makes me certainly think. So thanks for the question. I think I can.
Yeah. Very good. Yes.
Hello. Hi, my name is Sahana. I'm a student here at John Carroll. And I had a question actually about something that I have been wondering about for a good amount of time. So actually, I'm hoping to self-design my major in entrepreneurial healthcare. So this is like definitely something that I'm interested in learning about. But something that but I'm also someone who's very involved in DIB work. And I'm really passionate about it and have been doing work since high school, college, in and out of it in schools, policies, things like that. And something I wondered is just like have definitely like equity in healthcare and access to it is definitely something that is not taken, I wouldn't necessarily say seriously, but we haven't been able to really address the gap in that as much as maybe, I mean, we've made progress, I would say, but definitely not there. And some people of color's pain still not taken seriously till this day. And I guess I'm wondering, like, what is it that maybe we can do, like, to, because I'm thinking more about how can I use innovation one day when I get out of college to be able to create something that will help, with creating more access for healthcare and actually helping close that gap where some people's pain is not taken as seriously, and I'm hoping that would somehow help with the health outcomes, and especially helping with accurate diagnoses and making sure that we're really caring for the people there, and it's not just we're running with a entire just a whole business and just forgetting about the people's aspect and the fact that we're at the end of the day dealing with people's lives. So I don't know, I was just curious to know, like, since you guys are already in the field, like, have you guys already been looking into that? Has there been any ideas that have you guys have heard that you guys think maybe we as a generation, or me as a student who's wanting to learn about this, what I can do, or or is AI something that might be able to help with this? I'm just kind of wondering what y'all's perspective is on that.
Yeah. Thank goodness for you. You're going to save the world. We talked a lot about it today, and I know you weren't able to be here the whole day, and that's totally understandable. We talked about part of this is a payer issue, right? And how we're reimbursed. And, it was highlighted in the pandemic. We don't have good access, and we're not equitable in all of our healthcare, and healthcare isn't accessible to everyone. And there's technology that has come out, like Care Everywhere, and there's different apps that start to connect people, but then you have a digital problem, right? We have an Amish and Mennonite community that don't use technology, that don't have electricity, right? You have other underserved areas, right, in East Cleveland that you can't necessarily have Wi-Fi, right? I think each community has its own intricacies that we're gonna have to solve for. I think it's got to start with where the Benjamin dollar goes and how we begin to funnel money and find value in the health equities and access here in this country. I think we're learning from other countries that might do a better job, but our system is different, and so how do we work within our system? But we have to think very creatively around this issue and how we begin to tackle it, because it's not the same for all. Some of it's financial, some of it's transportation, some of it's access in other ways, and technology, et cetera. But I think thinking about it and how we train the future, how we integrate technology, right, and how we begin to involve and get into our communities. And I think for us, our nursing students are in really vital positions. One, to go out into the communities, with healthcare providers to begin to tackle some of these issues in a very low-cost model. So maybe it's a mobile health van that we start, right? The food buggy, right? Like, how do we leverage that and our student base to begin to make a difference, I think, in the short term?
Question is, so are you saying that this is mostly something that can be helped solve with innovation, or mostly a policy kind of thing? Because like sometimes they can intersect.
Some of it is policy. Some of it's the way our healthcare system is designed. I believe I think we've tried to transform it. At one point, do we decide we're just going to throw it up in the air and start again? I don't know that it can be transformed. Yeah. So part of this, and then I think to the business panel that was just here, Julie sort of said, and David said, we have to work in the confines of where our system is. So are we going to move the needle? How far in the current system, what can we tackle? So I think part of this is a design of our current healthcare system. What do we need to innovate to change the way that our healthcare is delivered to be more accessible and equitable? But then also, what are the roles or developments or technology that need to be bolt on in order to assist? I don't know.
So would it be too optimistic to think innovation can maybe challenge the systems that we do have? You think that would be too optimistic?
I mean, it should be optimistic. I mean, I think we have to be optimistic, but I think there are probably little steps we have to take to make the big difference overall. Sometimes innovation isn't like the candle to the light bulb, right? Sometimes innovation is incremental steps in improvement. And I think this issue that you're talking about when it comes to health equities and access is going to probably be an incremental approach to solving the bigger issue.
So what I wanted to ask you, though, because what I was hearing, and maybe taking a note out of your book, is I want to make sure that as we talk, we also maybe hear, and I was hearing something different. So I think what you were talking about is when patients present, and depending on your color, maybe sometimes your gender, you may say something that someone else dismisses. Like expressing, I have pain. And so it's really about that bias. And, we've talked before about as you diversify the workforce and people who look like other people, caring for those people who can relate will help with some of that. But I think what you're getting to is their innovation and the ability to translate around bias that exists. I think that's what I was hearing. Was that correct? Okay. So I don't want to have a public disclosure on your innovation, though, because there might be something there. I'm not sure who will pay for it, but that's one thing you always have to be trying to forward think on is who might pay for that innovation, even if I can overcome that. And that's a lot of what you were alluding to. But I just wanted to,
thank you.
As a moment sitting closer, I'm like, I could hear a little bit more of what she was saying, so thank you for letting me try to bring light on that.
The fact that a few years ago, I was in a panel talking about a similar topic, and there was a profound disagreement between the observation of there is a bias versus there is not. There's so much progress we need to do, but the fact that we are sitting here and there is not a fight about that is because of technology and innovation. There is measurements out there that's coming out, empirical data, that your skin color and pain scores don't match. So, being the optimist, I think to your answer, we have to believe technology has an inherent, innovation has an inherent factor in helping us. It has helped so far, not in solving the problem. So, that's why I kind of keep quiet on this. We have not even, but we are trying to quantify the problem. And that is something to be, okay, that's step number one. Do you admit you have a problem? And the problem is staring at us.
Well, I've been holding this for a minute, but actually this was a thought that I had earlier this morning and sort of sat on. But one of the huge challenges that I saw as a former practitioner in medicine was that medicine is 24 hours a day, 7 days a week, 365 days a year. And when I taught a class, I ask people, okay, how do you want to practice? You know, what do you want it to look like? And they say, well, I'd like to get my kids off to school and blah, blah, blah. So maybe I'll start my hours at about 9 o'clock, and I'd like to be home when they get home. So maybe get out about 4 o'clock. So maybe quit about 3:30 and do a half hour to tidy up loose ends. Then I turned the question around and I said, well, how do you want your pediatrician, for instance, to be available? Oh, well, they should have a couple nights where they go till 8 o'clock. And maybe since I start work at 9 o'clock, maybe they're there from 7:30 until 9. And there's a basic disconnect. And I think the question or the issue is this for you or is this for your patient? And that's the question I challenge everybody to answer in here.
That's a good one.
Okay, so I'm leading a year-long professional development group of young research administrators, and we're diving into a book called Dare to Lead by Brene Brown. I see some heads nodding. And I love a lot of what I'm hearing today because to lead, you know, we, as she uses the term, rumble with vulnerability, right? It is not bad to be vulnerable. And in my job here and all the other jobs I've had, my job is to support that forward progress, the innovation, which means the first thing people have to do is feel open and free to discuss their innovation in my office or with me. So there's a lot of trust creation going on, and maybe I'm just eternally, positive here, but I really feel like if you build that space, you give people that space, we afford our nursing students, our College of Health students, the space to understand that from vulnerability, from your willingness to rough draft think, whiteboard think, you will fail forward, you will bring policy change. You will impact healthcare outcomes eventually. You will work in what the world is becoming, which is an interdisciplinary world, right? We don't work in silos anymore. We know what happens there. So all this to say, thank you. When I go back and teach my next cohort, the first Monday of November, I've got more stuff to give. But it reminds me of that great book, and I think it's a great message today.
Thank you. So I have a question for the audience. What topics do you want to see next year for the Unconference, or any other format design you'd like to see?
Thanks for that question. I wrote it down because I was going to email you later.
Oh, good.
So I think that I loved that the topics today were intentional and very relevant. And they were also relevant on this campus where we're focusing on a lot of what we heard today. I think what I've heard in breakouts, and especially in the morning, was payer restrictions, reimbursement. It'd be fascinating to have some payers or some integrated payer delivery systems here. And also, we talked about it in the breakout, government relations, maybe some of the local representatives or senators that you have here or on the federal level. But they're a big part, and they drive a lot of how we respond or how we advocate. So I would bring them in, and I would encourage maybe thinking of this is a team-based sport, and bring in other providers alongside the nurses. And we've talked about this in the design sessions of what the College of Health should be and what the nursing program feels like. It's a team sport, but those would be sort of some ideas.
Thank you. Yes. She's coming.
Just to build on what she said, is if we could also bring in some of our controversial friends from England, Canada, just to demonstrate there are other ways, and we can think about them.
It's really great, an international look.
The most favorite unconference I have ever been to before this one, this is not my favorite, was a workforce unconference, and we were, there were seating arrangements, and you were meeting everybody at the table. But when it came to the design session, it was not disclosed to all participants that there was a homeless person or a person displaced from work at the table intentionally. And it was really powerful. And I know that we are all able to represent being patients as we're modeling this, but I just kind of throw that out there by even, like, we might all be in on that secret, but the next people coming in wouldn't know. So just something innovative to think about in terms of, I don't know how they train those people to kind of keep it to themselves until we got to the design session, but just even in that moment, you were like, oh my gosh, like you're sitting with the person you're really kind of designing for, which was pretty powerful.
That's awesome. I'm doing a murder mystery party for book club next week, so maybe I'll get some tips on how to keep that under wraps.
Just to build on what's said, this has been wonderful, though, just to start off and preface. Stakeholder alignment, perhaps, both internal and external, and how that relates to sustainable change management and the life cycle of what change management is, especially as it pertains to the history of quality in healthcare. I feel like that's the big elephant in the room, and perhaps when we think about networks of hospitals that have banded together, just as has been alluded to, perhaps learning, kind of seeing what the sharing success stories and maybe perhaps lessons from what's been done thus far would be important.
Yeah.
And then just like thinking about the 4 Ps of healthcare: producers, providers, payers, and patients. I don't think there's a payer in the room.
Yeah.
But we do have an IDFS in the room, UPMC, right?
Yeah.
So that there's a lot of potential there, and there's a lot of ways to either look within the U.S.
Yeah.
and also the external surroundings when it comes to stakeholder alignment. I would love to hear more about that.
Yeah.
Support. So.
Thank you. You got one up here?
This format where you're getting live feedback
Yeah.
at the end of it. That's good.
Who wants a survey?
Yeah.
So on the other side of healthcare, in the academia side with nursing education, I applaud you. You know, that's a great idea to kind of lease educators in the clinical setting. I'm interested to see, you know, how that comes to fruition and how that works. I've been in nursing education for the last 12 years, and it definitely needs transformed, and it's such a struggle to overcome that resistance of change and the financial struggles of being able to pay clinical faculty. I make twice as much if I were to go work as a bedside registered nurse. I make twice as much as I do working with my master's degree in nursing education. And I work much harder mentally in nursing education than I do at the bedside. So there's numerous struggles. Right now I'm leading a team of faculty to implement an assessment using high fidelity simulation for competency-based education to meet the new essentials that have come out from our accreditors. And so the more I'm delving into this project, I don't know if it will be sustainable, you know, for the future because of the cost. That it basically, to educate a nurse, and like someone else had, I think one of the, on the business panel mentioned, we are expecting our students to graduate with the skills that most of us gained during our, once we went out and got employment and through that practice. And we cannot do that with nursing students these days. You know, there's legal requirements. We cannot let them do certain things. They aren't able to communicate with providers on a regular basis. Most of the 8-hour clinical day is completely wasted time for the majority of the students. And I only know because I've taught clinical many, many years. And so simulation is a great way to overcome that, but that is also costly to do and time intensive. When I had a meeting with our dean, basically you need a one-on-one education model to perform simulation the way that it should be done according to best practice. So I think maybe the long point of my speech is maybe our regulators need to come, the Ohio Board of Nursing, maybe the financial boards of universities need to come and be a part of this and listen to the struggles in person. You know, and I don't know what happens with meetings with the financial people. I'm not involved in those. I only know the frontline struggles of education and trying to produce competent, safe nurses in today's world, which it's not happening, obviously, because that's the feedback that we get from the clinical sites, the clinical partners, is they're not ready. They're not ready to safely prepare to take care of patients, and that's probably some of the reason why they're leaving in mass exodus after a short time, because they realize they're never fully exposed to what it is to be a registered nurse on a regular basis. They have little pieces and parts throughout their nursing education, and so when they get out there and that they are taking care of patients in real life time, it's very overwhelming, and they get burnout very quickly and say, I'm not doing this anymore.
Thank you.
I have a question for both of you.
Yeah.
What are your I will statements?
Go ahead.
Yeah.
Well, I will continue to be part of this conversation. I think that's my commitment. I've made this commitment pretty early on in my career. In the last 3 years, we have done this. This is our third year, and so I will be here next year if and I hope that's part of the plan. Interdisciplinary, and I'm a systems engineer. I have a PhD in oncology. For me, being in a nursing conversation is uncomfortable, but my I will statement is I will be here. I will continue to understand what this is like. This is the biggest problem that we need to solve. You're $1 trillion out of healthcare. I don't care what you believe in. You build roads or you want to buy bombs. That's the opportunity we have. We have $1 trillion worth of opportunity. So my I will statement is, I'll show up next time if you guys do it. And I'll probably come, I have homework to do, and I'll do it.
I will continue to be uncomfortable. And with that, though, we are ready to close. I'd like to invite Dr. Al Mikiak up to the podium, who's the president of John Carroll, to give us some closing remarks. Thank you very much, Balaji.
Well, good afternoon, everyone. Okay, look, I have my motto is must be present to win, right? And not only present physically, but present, mentally. And you never know when you're going to learn, where you're going to learn. You have to show up and be present. So thank you for your presence today. In many ways, thank you for the work that you do, and in supporting our initial startup of our nursing program and our College of Health. Thank you for any guidance that you provided today and any guidance that you might provide. So I didn't know what an unconference was, and then I looked at the agenda: breaking bread, love, learning, business, innovation, and now flourish, okay? So now I know what an unconference is. This really is an unconference, and I'm wondering why I was asked, right? Now, Melissa did throw out, I could come and do a welcome, which takes a couple of minutes, and, everyone feels good about it, and I wasn't available, and I got stuck with the close and flourish, okay? So I'm not sure why I was asked to do that, because I have no expertise in healthcare. I'm not a particularly good patient, right? So now we have an unhealthcare unconference, right, as I'm closing it off here. But I did want to talk about flourish. I think it's an interesting word. We talk a lot about it at John Carroll. We're here to build inspired futures for students. It's about human flourishing. It's a Catholic intellectual tradition. And I think St. Irenaeus captures it best, which is the glory of God is man or woman fully alive, right? So this idea of human potential is all about flourishing. And so you're going to have to, I'm a president of a Catholic university, and I'm going to blend that with some lessons or some insights I have that may or may not be relevant to the healthcare context. But I'll try to pivot between the two. So when we look at priorities in Catholic education and Jesuit education right now, we have the Society of Jesus, the Jesuits, who give us some inspirations. It's a 500-year-old tradition, constantly evolving and modernizing. And I think, how do we look at healthcare through a modern lens? How do we innovate? But how do we look at the work that we do? And so they've provided these called the 4 apostolic preferences, right? And apostolic is Jesuit for work, okay? So it's just, we are an apostolate, means we're a university, we're work. They don't call me the president, they call me director of the work, right? And the work is important, the work matters, like the work of healthcare. So they have 4 preferences or 4 priorities. And I think first is really this idea of finding God in all things, right? And this is that we are all in the image and likeness, right? And we deserve special attention and care and focus, right? And I think how that relates to healthcare is obvious, right? In the caring professions generally, right? So this is I think the spiritual connection that comes from caring for one another. So second priority, walking with the excluded, right? Walking with the poor, the outcasts of the world, those whose dignity has been violated, and in a mission of reconciliation and justice, right? So I heard a little bit of that this afternoon, right? And certainly this idea of health outcomes disparities, right? That the color of your skin or your zip code should not be dictating the quality of care or life that you live. Third one, journeying with youth to a hope-filled future, right? And this is really, how do we accompany young people? But I look at, obviously it's front and center for a university. The students are at the center of our attention. But in the healthcare world, right, this is generating the next generation of healthcare providers, right? Whether they're young nurses, doctors, all the pre-health professions that go with that, right? So again, very important work. And the 4th priority, caring for our common home. This is Pope Francis in his encyclical Laudato Si, really talking about the earth, right? And some will interpret that as the environment, all right, climate and so on. But we're talking about global obligations and obligations to the globe, right? And how do we, invest in ways, right, to solve problems, not only in our own backyard in our own country, but the issues that face humanity at the global level. So the question for us, right, all this raises a very important question, which is, are we reading the signs of the times, right? And this is all about, for me, relevance, right? Things change, right? With that change comes a lot of tensions, right? And our work as leaders is both to create the tension, we heard about that, right? We have to innovate and change, and our role is also to resolve the tensions, right? To help solve problems, right? And bring, innovation and more impact, more effectiveness to all the organizations that we lead. So, as a Catholic institution sponsored, by the Jesuit, the Society of Jesus, we are also doing the work of a university, right? So it's Catholic intellectual tradition informed by the Society of Jesus. It's faith in dialogue with science, which are mutually illuminating, right? But how do we, our goal here, how do we create a sense of belonging and environment for a big variety of people on our campus? And this is what we work on every day. So I learned 2 things I'll share with you over, one, 25 years ago, right? If you've ever read Jim Collins in his book, Good to Great, he talks about strategy, and he uses this, you have to preserve the core and stimulate progress. So this is his idea around, or his ideas around innovation. And he uses the symbol, the yin and the yang, right? Which is, typically meant that something that look opposing are actually complementary, right? So in the healthcare, which is a high-touch business, how do we use tech, right? And so tech and touch they're not complementary, but when we're delivering remote care and so forth, we can be very effective in environments where it might be impossible to see a person, face to face, right? So we look at that, and I look at that on a daily basis, right? How do we bring, right, honor the past, right, by blazing the trail of the future, right? So how do we make the yin and the yang work? And it's not easy, right? I think it was mentioned in the panel, right, that there's a lot of resistance to any change in any system. And, we are no different, but that is the work. The other thing I would share with you is something I learned, only 2 weeks ago, right? I heard someone talking about, when we focus on the imminent, we jeopardize seeing the transcendent, right? So in our world, when we educate for the imminent, we lose track of the transcendent. So yes, students want, good grades, they want degrees, and they want jobs, and we're all focused on that. But, right, what's really more important, in the long run, right, are things around character and fitness and, understanding the breadth of the liberal arts and how do you bring that together with professional education to live a life of meaning and purpose. So when you start to think about, how do you encourage people, when I hear about all the burnout and, this work-life balance kind of conversation, it really revolves around the imminent, right? And I think you can get people's focus off the imminent when you can paint an inspirational picture of the future, right? The work that they do that matters. And so I think this is a big challenge in the workforce today, is to get people that not only understand the mission, right? They understand that their work matters, and that becomes, what's important to them, right? And sometimes it's not all that obvious. You talked about taking out the laundry, right? Well, taking out the laundry is a very important activity. Cleaning spaces, a very important activity in health. So this is the struggle I think we all have on how do we incentivize and motivate in this particular time, right? Are you reading the signs of the times, right? Listening to your employees, what's challenging them, and how. But I would argue, right, you're not going to, win them over by dealing with just the imminent, right? You have to work on the transcendent, and I think there's nothing more, transcendent than, the healthcare business, right? I mean, this is a highly aspirational call. So every endeavor, I think, every field of endeavor, there's this tensions, right? Lots of tensions, and I've just kind of identified two of them. But if you can imagine an author of a best-selling psychology textbook looking out at the world and sharing this observation, right? So voluntarily bringing back a wandering attention over and over again is the very root of judgment, character, and will, right? So here's the quote. Voluntarily bringing back a wandering attention over and over again is the very root of judgment, character, and will, right? So this is a superpower, and I'll just call it focus, right? Now, could he have been pondering the 20 billion text messages, nearly 85 per person, sent between the world's people each day? Or was he reflecting on the 2 hours and 27 minutes per day the average person spends on social media? Some of these doing 5 hours because I'm doing none at all, okay? So, or the 159 times a day that the average person checks their mobile device, right? The link would be obvious, right, if this person was writing this quote today, but it was William James, considered to be one of America's first great psychologists, wrote a 2-volume Principles of Psychology in 1890, okay, a century before the smartphone, the internet, even before the assembly line and the invention of the zipper, right? So if you employ the superpower of reining in your wandering attention, right? And I can give you a healthcare example here. A few years ago, I'm having my, physical with my doctor, and he says, Al, how's it going? And I said, well, I have a little numbness in a couple of my toes. He said, yeah, that's okay. We're not going to worry about that. I said, well, I have a little bit of arthritis in this knee. It flares up every now and then. He said, yeah, we're not going to worry about that. And I said, you know, as I'm getting older, the frequency of my trips to the bathroom are increasing. He said, yeah, we're not going to worry about that either. But he did do a calcium scoring, you know, which is you know, an assessment of your cardiac, you know, health. That led to a trip to the cardiologist, right? That led to a stress test. That led to an angiogram. That led to a coronary artery bypass, 6 grafts, okay? So, reining in his wandering attention, or reining in my wandering attention, focusing on what was important, right, really produced a very good result. At least I think so. So, you know, when you look at this idea of focus on flourishing, right, and how do you rein in the wandering attention, right? How do you keep bringing yourself back to what is important, regardless of your field, your endeavors, your goals and objectives, right? This is really, you know, a great insight that I got, and I didn't, you know, read it in 1890, you know, only in the last couple of months, right, that I kind of stumble across this thinking. And it keeps me focused, right? It keeps me focused, and I see it all the time, right, in people who are really making differences, right? They are focused on, right, the important things. And again, I would encourage you all to reflect on that. So the College of Health is a vital initiative for JCU. It enhances our mission of service to others, right? This is a big part of, you know, the Catholic intellectual tradition, and it's also a big part of the Jesuit legacy. We have, you know, strong, you know, initiatives in pre-health professions, counseling, exercise science, behavioral health, now nursing, a future in public health, and the business of health. So we're really grateful for all of the support that we've been receiving from all the hospital systems, Metro and the Cleveland Clinic and UH. You know, we intend to be and are committed to be a collaborative partner, right? I think we can flourish together in that way, right? And I'm very excited to have Dr. Cole as leading our College of Health and our nursing program. She's made a, you know, huge difference on not only the quality of what we're doing, but the speed at which we are moving, right? Because she's not used to how slow you're allowed to move in academia. So let's flourish together. My wish for all of you, right, is that you're blessed with great clarity in the face of all the tensions of our times, right, as you're reading the signs of the times. But for me, you know, I will continue to engage with the questions that are both eternal, right, and contemporary, embrace all the creative tension that is put in my way, and rein in my wandering attention, okay? And I wish that for you also. So again, thanks you for enduring the rest of the moment, right, that with me, it's warm, it's late in the day, you're tired, and I think we have some refreshments. Okay, we'll see you outside.